So the one goal that we have usually when we look at pregnant mothers and their kids is usually that we want to save the mother, and goal two is to save the fetus if possible. Uh, so just to do a physiology recap, the pregnant uh, lady has a gravid uterus, and this uterus, this abdomen is really big to carry around. And I'm sure the pregnant ladies can testify that sometimes can make you quite unbalanced. And in this respect, it makes evaluation very difficult. And this big abdomen is definitely susceptible to trauma. Other things to consider is an increased risk for aspiration. There's an increased abdominal pressure with a relaxed lower esophageal sphincter, and this together gives them an increased risk of aspiration. Another thing to consider is that the peritoneum is quite stretched, and this makes it less sensitive to irritation. Sorry. So a traumatic hemoperitoneum may not always be exhibited in the case of trauma. And yeah, we should be more vigilant when we examining the abdomen of a pregnant lady. So on the hematological side, they have increased plasma volume, and it doesn't always mean that they have increased red blood cells, and could create a dilutional effect. So they could be anemic. They have a hypermetabolic liver, which makes them hypercoagulable. On the pulmonary side, they have a clinically compensated respiratory alkalosis with a baseline CO2 of 30 because of the decreased, they also have a decreased respiratory reserve because of the elevated diaphragm. They have a physiologically difficult airway. We know the airway is edematous. Yeah, most of them have a short neck, so we always classify them as a physiological difficult airway because also the increased risk of aspiration. As far as your CDS is concerned, they could be tachycardic, they could have a normal blood pressure. And the one thing that we have to remember is the vasodilation. So especially in trauma, when assessing the vitals of a pregnant lady, it's not always reliable. Hypotension is usually a late sign and is a red flag. And when we say hypotension, we must always consider some type of bleeding that's happening, whether it's in the uterus or in the abdomen. So that's just basic 4 systems that I've included. Of course, there's other things that we have to consider as far as the physiology is concerned, but this is just to give you a kind of a recap of things, the changes that happen. So when we look at the pregnancy-related injuries, there's 4 that comes to mind. So when a pregnant lady is injured, whether it's an MVA, whether it's violence or any type of injury that you can think of, the first thing that must cross our minds is that she could go into premature labor at any time. So it's very important that when they come in, we assess the mom as well as the baby. And when we assess the baby, it's important to do togonometry. So we want to do a tracing of the baby's heart rate and monitor that. The second thing that you have to consider is a placental abruptio. They don't usually present with a triad of PV bleeding, low abdominal pain, or abdominal pain. Like you said, the peritoneum is insensitive. It's not always present. Ultrasound can be helpful, but it can't rule out an abruptio. It is advised to do togonometry for the minimum of 4 hours. The third thing that we have to consider is uterine rupture. And usually when this happens, there's 100% mortality. And it's usually also associated with pelvic fractures. And when you think about the physiology there, it's very easy for a pregnant lady to sustain a pelvic fracture. I mean, everything is loose down there, getting ready for, the birthing process. Just to point out, the abruptio is actually the leading cause of fetal death, even in minor trauma. So we need to, be really alert when we assess the patient. And the last one is amniotic fluid embolus, which puts them at risk for a PE. But, of course, there's other maternal injuries, but I just wanted to focus on the pregnancy-related ones that usually can be missed. So when we assess a pregnant lady, we have to follow the ATLS principles as we would in any other patient. There's two patients that are at risk. It's the mother as well as the baby. And according to stats, MVAs are the number one leading cause of non-obstetric deaths that result in 40 to 50% of fetal deaths. So it's important to follow the ATLS principles and always consider the mechanism, whether it is minor or major trauma. It doesn't equate to a minor injury. You can't say, no, it was just a minor trauma or minor MVA. So, the patient won't have major injuries. So as usual, we should follow a trauma algorithm, do a primary survey and resuscitation, get an early obstetric consultation, follow through with a secondary survey and have a definitive treatment. What is also important is to have the patient in a lateral decubitus position, because we want to get that venous return back. We don't know the extent of the injury, so it's always better to be safe than sorry. Even though the patient is walking and talking and the vitals are stable, remember they are just out of an MVA, so they could still be having an adrenaline rush. So it's important to have all our bases covered. A normal blood pressure does not mean a normal circulation, especially in pregnancy. And early volume resuscitation is essential. When it comes to physical examination, it's important to do a complete physical examination from head to toe, and to monitor the response to the initial resuscitation. So when it comes to your abdominal examination, you check for any deformities, bruising, scars, feel the abdomen, is it rigid, measure the fundal height if the patient is unconscious and we don't have a gestational age, check for uterine contractions, and monitor the fetal heart rate. When we, just back on the primary survey, sorry, I just forgot to mention, we still follow airway and C-spine protection. It still remains the main priority. Give oxygen if the patient needs oxygen. When it comes to your circulation, check for hemorrhage, any signs of hemorrhage. If the patient is presenting within 3 hours, you can consider TXA. Make sure the patient has 2 large bore IV lines. When you put up your IV lines, take blood and a cross match as well. If you have fluids for your resuscitation, you can start your fluid resuscitation, but blood is usually preferred in trauma. Make sure you check other parameters. If the patient comes in and she doesn't appear to be in shock, make sure you check other parameters to evaluate the shock state. So you can make sure it's not just the blood pressure. So you can also look at the heart rate. You can look at the perfusion, the cap refill, and feel the peripheries. So hypotension is a late sign and it is a red flag. The mom shunts blood from the fetus, and the placenta is usually very sensitive to catecholamines. So vasopressors will compromise placental blood flow as well. When it comes to disability, you assess the GCS as well as the HCT and the pupils. Exposure is important. It cannot be omitted. The patient requires a complete head-to-toe examination. When we speak about the fetal heart rate, I'm not sure. I don't think we have one in the ED, but it's important to attach the mom to a monitor. If the heart rate falls below 120, you can consider this as a fetal distress. And this is important because it means there must be some maternal blood loss somewhere. An EFAST can be helpful, but it can identify free fluid in certain areas in the abdomen. It can identify tamponade, hemothorax, but it's not sensitive enough to identify an abruptio. Investigations, this is actually quite a big thing. When it comes to a radiographic imagery, there's always a fear of radiation exposure when it comes to pregnant patients, but it does not take precedence over establishing a definitive diagnosis to allow for optimal management, because we always go back to our primary goal, which is save the mother, and the secondary goal is save the fetus if possible. So the care of the patient outweighs the risk of radiation. And I mean, you guys are free to comment on what I've got down here. So as far as possible, missing an injury is actually a greater loss than, not doing the workup. I just did a little bit of reading, and I noted that the accepted level of radiation is usually less than 10 rad. X-rays result in 200 microrad, which is very small amount, and a CT is 3 to 4 rads. Ultrasound and MRI is the safest, and according to the ACOG, American Council of Obstetricians and Gynecologists, X-ray exposure less than 5 rad poses no risk to the fetus. So, they do not encourage staying away from this. We shouldn't deprive the patients of having their investigations. Other things to consider, obviously, is bloods and VBG, TXA if the patient is bleeding, CVPs if the condition is quite dire, and we don't prefer femoral because of the pressure on the femoral vein. So subclavian and jugular is preferred. Always do a cross match. And an RH, always make sure we know the booking bloods of the patient in case she needs an anti-D. ATT is important. It's safe in pregnancy. Monitor HCT and then ongoing fetal monitoring as well.